time of enrollment. So they engaged Medicaid without prior health care coverage. That is absolutely the opposite that everyone was trying to explain would happen, where all employers would drop everyone and people would all move to the exchange or they would move to Medicaid. That may in fact be somewhat truthful when you talk about the exchange. That was not the case with Medicaid expansion. 89% came into expansion coverage without prior coverage available to them. Some other things we found out. We certainly understand that social determinants of health is real, it's meaningful. Maslow had it right. There are some things that we need in order to make lives work correctly. To that end, 62% showed up with a depression diagnosis and received antidepressants. That was such a big number. We were very surprised with just how high it was. 48% reported an improvement in their health status. I got to tell you on this one, when you see one of the other ones that I think is going to be up here, if it's not, it's the 27% that found out that they had 2 or more chronic health conditions that were untreated. There are a few in that area, in that 52%, they were pretty doggone annoyed they found out that they had high blood pressure, high cholesterol, and diabetes. So they weren't any happy about us bursting their bubble on their own health status. 49% easier to find food, 48% easier to get housing, 52% easier to continue working, which is what the goal is, right? It's all about jobs and what allows people to have a more independent, stronger life. 75% found it easier to look for a job. Go back to those initial conversations where you're hearing about somebody who says, you know, I haven't been able to work because I've needed knee surgery. I haven't been able to work because I needed a hip replacement. I haven't been able to work since my auto accident and my shoulder got screwed up. Now being able to look for work again. 45% reduction in individual medical debt. That's not a real surprise. The benefit to that is the percentage of people going bankrupt because of health care is less. 44% found it easier to pay off debt. Shockingly enough, if you work, it's easier to pay your debt. I know some people were really surprised by that fact, but it is nevertheless a fact. And so truly the idea of looking at those social determinants of health and now trying to bring them into the healthcare, into the Medicaid space for us, and figure out how we value a return on investment in that space so that we really can begin to have an integrated conversation of what social determinants of health means to using less health care by essentially having events that never occur. So that becomes incredibly impactful. In addition to that, a slide I don't have up here for you, but certainly do on the website if you're interested in it. Ohio currently spends, in a very focused and specific way, well over $1 billion in our opioid issue. And we do that through basically 14 different state agencies, everywhere from education to Medicaid to mental health and addiction to aging, to our developmental disability, to our law enforcement, to all of our different agencies. We're spending those dollars in order to provide access to care in the area of our opioid work that we are doing, simply because, like a lot of states, Kentucky included, it is becoming a generational devastating factor that will only go to not only destroy lives, but increase healthcare costs as we continue to move forward. So how do we take some of that information and think about some of the other areas that we're doing work with, and particularly when I think about some of these areas where we're looking at social determinants of health in our low-income families. One of the things that Ohio did was we worked with the federal government when they came out with the duals program, and we said, well, how can we work with the duals program in the state of Ohio? So a few years back, we became one of 3 states that really took on the duals program, that marriage of Medicare and Medicaid into a single program for our folks who by age or disability qualified for Medicare, but by income qualified for Medicaid. And we did that through our duals program. We call it My Care Ohio. It got off to an awfully rough start. It was a unique and interesting opportunity to go to school on how not to start a large program in a state. And yet, you know, we are now at a master's level on mistakes, and we are rolling out hopefully what will be a program that will have some sustainability. So we looked at Medicare, our senior folks. We looked at Medicaid, our low-income folks. And we said, how do we make this all work? So we picked 29 counties out of our 88, our most populous counties, and looked to roll out the My Care experience. Using our private managed care plans, we were able to offer additional level of benefits. There are actually 21 unique services that aren't found in a Medicare program, that aren't found in a Medicaid program, and we were able to offer those out for seniors and then gave them the opportunity to opt into our MyCare program. In the state of Ohio, we have roughly 70% of those that are eligible to opt in have in fact opted into our MyCare program. Which is a dramatic number when you consider that is probably the highest number in the nation, certainly has been. I don't think anybody's coming close to passing us by in our opt-in rate. We are outpacing national averages on care plan completion, on plan goals, and on follow-up visits, and we're ranking over the 90th percentile in nearly half of our HEDIS scores. And this is with an opportunity to opt in just 29 of our counties. But what that is really translating to is not just a higher quality of care, not just higher independence, not just higher quality of life for our seniors who are within our duals program, but it's also translating into real life meaty things. It's translating into our ability to get over 10,500 of our Ohioans out of facilities and into home and community-based services. It's our ability to give people more options to either stay out of a nursing facility or return home to one after a stay. And it's really looking at those exact things that we looked at with our MyCare study and how we looked at that data and how we allowed that data to inform us and how we needed to recreate some of our home and community-based areas in order to give folks more option. From a hard dollar standpoint, it translated to about 4% less bed days in our facilities, which is $2.4 million each month that we are saving by not spending those dollars in nursing facilities, but by spending those dollars and moving them to home and community-based services, all while not reducing the cost of what we're spending on nursing beds. So we've been able to kind of marry that as an opportunity to see some great success. The MyCare capitation rates, that's the rates that we pay our managed care plans to manage the plans. We have been able to see a reduction in that, and that is, again, because we've been able to move more folks out of facilities. So that was a great opportunity for Ohio, and again, here's the $2.4 million per month just by moving folks back where they want to be, giving choice, right? Giving folks choice on where they want to live. And again, MyCare plans approved more than 90% of our prior authorizations. I never know whether this is a good statistic or a bad statistic. A lot of people think 90% of prior approval is really, really good, but that means that we've stopped 10% of things that potentially are really bad for people. And so I never really know whether I like that at 90% or not. It sounds good, it's a great soundbite, but when you think about prior authorizations really preventing something that maybe shouldn't happen in the first place, you need to kind of think about where you like that number to be. And then lastly, kind of our one-pager on our MyCare report. And I put this up here knowing that we're talking about data because this is really what this is. 70% of folks opting into a plan, which although got off to a very rough start, never had low numbers when it came to patient satisfaction. We had an ability to pay problem is what we had. And quality of care up over national averages, really within just the first couple years of this, which is stellar as we're recreating how we managed care. Member choice and independence, because that's really what it's all about. Just because you're a senior doesn't mean that you shouldn't have choices, have opportunity to make good choices and bad choices in your life. You should still be able to be independent and make choices. And then safety. This was huge for us. We had several issues, two real quick ones I can highlight for you. One where we had a facility where that air conditioning went off, and on about the 6th or 7th day of 90-degree temperatures, somebody finally notified the Department of Health, and we were able to go in, and because they were a MyCare plan, we were able to virtually move all those residents within a matter of hours, not days. The second one was a facility that it was about 3/4 MyCare residents and the other ones were not. We moved the residents that were MyCare within 48 hours. We had virtually all of them moved, and they were in a facility that lost heat. And the emergency plan for that facility was actually to warm blankets up in the dryers and put them on people in the hallways while stringing space heaters. we were able to move them in very, very short order. And then, of course, the Florida issue that we just saw with the flooding down there and how dramatic it is tells us just how quickly we need to move forward on these issues. And the MyCare program allowed us to do that. So with that, I will close and allow our next speaker. Thank you.
Thank you, Director Sears. It's really clear from your data how important health insurance is and what it really does for people. And so the expansion of Medicaid, continue to say, is something we need to keep in both of our states. So next we have up Dr. Liu to talk about Kentucky.
Thank you. These are some tough acts to follow. I feel like you've been served a gourmet meal and then I'm bringing you gruel for dessert. All right, let's see how this works. It's a point that gets hammered home frequently, but I'm going to do it again. So Kentucky Medicaid covers 1.4 million people in contrast to the 3 million that Ohio covers, but our total state population is 4.4 million compared to your 12 million. So it's proportionally a large percentage, right? Almost 4 out of every 10 children rely on Kentucky Medicaid for their access to care, and about 1 out of every 3 adults. And the pie chart that's turned on its side there is our last state budget, and all of the things that we allocate those precious dollars to. 1/3 of every dollar in Kentucky is allocated to Medicaid. So you absolutely want that program to be highly data-driven, completely evidence-based, and proven to be effective. We were very proud to be an expansion state because we had such success. Other states had expansion, but they didn't get the enrollment in that they hoped for. Not the case in Kentucky. But what did we learn after we enrolled? We had this infusion of new middle-aged adults, very similar to Kentucky, with these very interesting and worrisome patterns of health services utilization. One thing that we saw is, people are going to get care whether they're insured or not. The costs are going to be incurred. If you're sick, you will find a way to get treated. And now what's happened is we've seen things like emergency department visits that were absorbed by the hospital as write-offs or covered by charitable care now coming into the Medicaid program. And similarly, probably more a phenomenon of timing and the emergence of an epidemic, but the lines over here are substance use disorder, in particular opioid use disorder. So along with this new expanded eligibility for insurance, we saw a lot of very expensive care, and I'm going to show you not the preventive services that you would like. And we're a highly managed care Medicaid program. So if you're younger than 25, let me see you raise your hands. A few. I thought there were so many. Where are all my youth build friends that were at the lunch table? I'm not so sure how many of you are familiar with kind of how Medicaid programs are administered, but when you go managed care, you're making a decision that national corporations, many of which are nonprofit, have the wherewithal, the entrepreneurial ability, all of their national resources to do a better job than government might do in running your Medicaid program. True or false, it remains to be seen. But those MCOs have got to get this expansion population, now that they're enrolled, to be assigned to medical homes and to improve this utilization. We've got to drive down the current experience of having people receive care in emergency departments and not at all in primary care offices, and when they're age eligible to get preventive services, many of which we see no evidence of in our claims. So I don't know if it's these lazy adult men that are hooked on their Xboxes, or if they just can't find good doctors like all of the ones in the St. Elizabeth system here, but we have our work cut out for us. Now here's the thing, you spend 1/3 of your state budget on an insurance program, and you invested a ginormous new amount of funding in that because you're expanded. What do you want to know? that you were spending that money well. And if you're not spending it well, most of us would choose not to incur a larger investment in a poorly performing option. So these bar graphs show that actually in Kentucky, we spend more on the commercial side and on the public side compared to the national average and to many other states. Healthcare costs proportionally more in Kentucky than it does in other states, and that's true for the Medicaid program. And what do we get for it? We did do our own in-house evaluation of the expansion population. That report is available to you on our website. But I would suggest that United Healthcare's foundation does a national ranking of states in terms of their health. They've done it for over 2 decades. Now, and if you look at the little dot graph over in the lower corner on my side, starting in 1990 and ending in 2016, Kentucky has never broken out of the bottom 10 in terms of its state health rankings until 2016, where we hit 39. Woo! And the metrics for that are well established. They fall into these main categories of access and affordability, whether you're getting prevention, appropriate treatment, you're avoiding, by virtue of that appropriate treatment, higher cost utilization, like preventable hospitalizations. If the people report healthy lives, number of days without a physical disability or a mental health concern that prevents them from living their normal activities of daily life, and then equity. And we moved up largely because we decided to pay a bunch more for the expansion population to broaden the gate for you to have insurance, but the quality of all of the other things, especially the avoidable healthcare cost, has long been, might we say, with plenty of room for improvement. And I joined as a chief medical officer back in December, so I'm new to this game. I'm not coming in with a lot of tradition or a lot of political connections, but I know that as a state, we have got to do better than this. We cannot continue doing the same old things, and data is absolutely what's going to drive those improvements, along with public-private partnerships and localized implementation of health policy. So let's do this together. We really need all of the brilliant insights in this room and in others to guide how we're going to get off the lowest, what is that? If you divide 50 into parts by 10, it's quintiles. Am I saying that right? You're asking me to do math live. That's no good. So I'm excited. One way we're going to reform the Medicaid program is we're going to look more broadly at what determines health. And over on that side is a very well-endorsed conceptual model of the predictors of health outcomes, which shows that clinical care, the part that we pay for, really only drives a small proportion of health. And what are the larger drivers? The social environment, the physical environment, a person's health behaviors, and a little bit of their genetic endowment. So we know we can optimize through the wallet of Medicaid, the clinical services. But even if that's perfect, somewhere between 6/10 and 8/10 is outside of that domain, directly connectable, so we can get at those social determinants. We should be investing in community revitalization, but the part that we have traditionally seen as our purview is only a small fragment of what we need to affect. So we're going through this 1115 waiver, and I'm not going to talk today about the 1115 waiver. Again, I invite you to look at the proposal, but the thing that I find most compelling about that reform is that more than ever before, it's going to look at economic stimulus, economic vitality, a person's employment status, and if we can drive that forward along with improvements in health services quality and access, then I think we can get off the bottom of the state rankings. And I think the conceptual model amply illustrates why that's evidence-based. And then as part of evaluating that, we're going to come up with the best thing we can. We can't do an experiment like Oregon, they sort of randomized. So they knew they couldn't get everybody into their expanded population. So they said, because we can't serve everybody, we're just going to randomly select who might go in, and they were able to conduct this experimental design. Instead, we're going to do a matched implementation between areas where we're going to have targeted economic stimulus, targeted community engagement activities for Medicaid beneficiaries, match them with other regions, and then see if we can detect how effective we were. Okay, I'm pivoting now. So that's the global kind of Medicaid program, large-scale reforms. I want to go right at a specific data use case that I'm really excited about, and I would love to talk more with you individually after today's session. And that's on behavioral health and substance use disorder. So thank you very little, Kelly, for preempting some of the slides in your panel right before this. I'm going to have to try to divert around and not repeat some of what you said. But the line graph is the average cost per capita on behavioral health and Kentucky's rankings. So we previously were super thrifty in terms of behavioral health payments coming out of the Medicaid program. And part of that, I actually want to temper, the criticism. We use state funds to pay for a safety net program. So those safety net mental health providers didn't have to bill Medicaid, but that's not true anymore. So those things have been moved into the Medicaid program, in part because it allows us to get federal matching dollars to really expand the behavioral health infrastructure. And right now, again, there's all these really worrisome patterns within the data. For example, we spend the majority of our behavioral health payments on drugs. And if you compare the amount we pay for drugs versus the amount we pay to clinicians to spend time caring for patients, the drug spend dwarfs the clinician payment. And so as we've tried to move more services into Medicaid, where we can track them through our claims, where we can expand the amount of federal participation, the dollars are going up. So it had been shown to you the amount of overdose deaths went from 1,000 per year to 1,400 in the past 2 years. The number of babies born with addiction out of a pregnancy that was complicated by exposure to opioids has tripled. And what do we need? What do we need to do from a Medicaid standpoint to address this opioid use crisis? Well, there's clearly a laundry list of items. We need to build new infrastructure. We need to eliminate stigma. We need to apply more effectively resources like care coordination, case management. We need to strengthen the payment for services. We need to monitor more effectively the quality. And then again, I'm glad to say that on the other side, hopefully some of the focus we have on just improving socioeconomic status is going to improve some of this as well. By virtue of our waiver, for the first time ever, we've linked employment data with Medicaid claims. So we know for Medicaid beneficiaries, the type of work that they've been doing, the salary ranges for that work. Very exciting. And, interestingly, by statute, by law, previously employment data was restricted only for unemployment insurance administrating. And still there's some pretty heavy barriers in the way for us to fully integrate information that's in the Cabinet for Workforce, Employment, and Education with the Cabinet for Health and Family Services. But this is going to be really exciting to be able to see on the employment side, the educational side, the job experience side, how that connects with health services utilization and health outcomes. And we know, in Kentucky, there's huge challenges for various parts of our state. So 50 of our 150 counties actually have had economic regression. They have fewer jobs now than they have had 7 years before. And really, the economic vitality is clustered around certain corridors, mainly those that interstates run through. And for the area of southeastern Kentucky, where we know there's a way disproportionate burden of opioid use, opioid overdose, the economic vitality there is just extremely concerning. We've taken all of our Medicaid beneficiaries, we've mapped their residential address, we're looking at where they're going. So one thing we're doing is just plain old geospatial assessment. And then when we map them, we can also count them. So in the bottom corner, you see Northern Kentucky, individuals who have had a payment where on the claim it said overdose somewhere. And then in the table, you can see large gaps, so many fewer people that have had overdose as a service, like a resuscitation in the emergency department. Very few of them have any claim for addiction treatment. Very few of them have any testing for toxicology test before their overdose event. Very, very few of them have things like a screening code for substance, screening, brief intervention, referral, and treatment, which is a very common, widespread, completely evidence-based expectation for determining if someone's at risk for opioid use disorder. So finally, I did want to say another new data connection is that we've merged our vital statistics with our claims, which I think relatively few states have done up till now. One thing that gives us is birth certificate data with payments for care, and for the first time then, we've hardly ever had success in really determining who is in a household for a Medicaid beneficiary. So now we have child, mother, and father based on self-report. And then we're looking, so I've mentioned workforce, for other ways to really interconnect data, at least within government, more than ever before. So we know we need corrections. We know we need justice and drug interdiction to get on top of this opioid use epidemic. And then we've got to figure out a way to overcome the FERPA regulations to get at educational outcomes, which are the #1 child health indicator you want to put on the dependent side of any analysis. So more than ever before, we're no longer going to be looking at infants with neonatal abstinence syndrome in isolation. What an inappropriate way of analyzing. We'll be able to look now at mothers and their prenatal care and what preceded their prenatal care. And going forward for mother-baby dyads, what's going on for the child's primary care, and how are they functioning even within a household with a third member, the father. And this is a gratuitous picture of the Liu household this morning as I was departing. Complete and utter chaos. But why do I show that to you? If you want to intervene on Mrs. Liu's child to improve their health, but you don't do anything for Mrs. Liu, or vice versa, you are just dead in the water. You're dead wrong. You have no idea what you're doing. So, and that unfortunately has been the approach of many Medicaid programs, to look at our aims for one side of the dyad because we just can't figure out how to reflect a family in our unit of analysis. So I'm happy to say, Kentucky's gotten beyond that. And I would love to talk with you about how we can de-identify, aggregate, or otherwise make this data available to you so that you can look at it and help me develop more effective policies. So thank you very much.
Love the family photo. So again, help me thank Dr. Liu and Director Sears again for their presentation. So at this point in time, we have the opportunity to ask them questions. And I actually have one for Director Sears. And Dr. Liu sort of got into it so he can expand on it if he would like, is being the fact, you are state agencies and you have access to all kinds of data, or could possibly have access to all kinds of data. If you could connect, and how to connect across your different departments in order to improve the overall life of everyone in the state, or give examples of how you are connecting data across your systems.
Sure, I'm happy to go first, and then you can jump in. So we're actually just right now in the beginning of doing a very large project centered around infant mortality, where we're actually connecting all of our different agency information to work to inform kind of a broader picture. And what I mean by that is, so like all states, we've got our data warehouses are all stored and generally managed by whatever that state would call their Department of Administrative Services. And that information just sits in there. Well, we're going to start to integrate our Medicaid claims information with our Department of Health vital statistics information. and start to take a closer look at what we get from that. And we're doing it kind of in a way that encourages both the largest, the Googles of the world, to look at the information, but also then the next generation's Google. So we're also looking to engage some of our smaller folks to look in and do some of the data analytics so that we can begin to look at something. So we've started to go through the process, and we've kind of gotten through, in some parts, the kind of the proof of concept on it. And we've already found out some really interesting thoughts and ideas. Number one, on our infant mortality, we have 9 priority communities around the state that we're focusing our dollars on, that we're spending in this biennium, we're spending about $27 million in those 9 areas. But what the data is actually starting to tell us is that if we were to strip away race, if we strip away age, and we strip away educational attainment, high school above or not, what's next in that list of social issues? And for us, it's violence. And so we looked at that, and then we said, okay, so if we took those 3 away and we look now at this component of it, would our 9 priority communities still be those same communities? And it's not. It's actually 3 or 4 different communities. And so being able to look at that information begins to tell us where we need to prioritize today, but where we need to not lose sight of for tomorrow, so that we can prevent that from being a bigger issue. So by looking at all 13, 14 of our agencies and integrating all that information together is really giving us a completely different look than what we were seeing with each individual agency.
Yeah, I would just make a brief comment that the technical challenges are the kind of smaller set of barriers, and often the larger set of barriers lies in the governance. And there, I think we need to really identify, because other states have done this successfully, kind of who should be at the table, what are the really appropriate and safe ways that data can be interconnected and used to mutual benefit. And then to go all the way to having more transparent government. So often, unfortunately, what happens is you hit a hard stop on, FARPA just says you can't do anything besides look at education, narrowly defined. But I think there's lots of ways that other people have looked to great value at a child's well-being, in large part, depends on his educational experience. Part of what determines whether or not they can have a good educational experience is their medical care or their parents' health, whatever the case may be. So I just think that governance can be so hard. And often, there's just really contrasting kind of desires for resources that are very costly. So the more we can get a lot of stakeholders kind of aligned and then commit to the difficult work of governing this precious resource, that I think is often very challenging. But
Yep, that it is.
Don't go too far. Okay, questions from the audience? Paul?
I want to say thanks to the Ohio people for getting behavioral health redesign finally close to actually starting
If
in
it were
January.
a child, it would be starting school next year. It's been a while.
It's a big deal in Ohio. And Kentucky has basically the same menu of things, except it has never paid for methadone for the people who need methadone. And there is a population that needs methadone. I was wondering, in Kentucky, when might that population have access to methadone? Everyone here at the methadone clinic, 1,500 people a day, pay $15 a day for methadone clinic service.
yeah, no, thank you for that question. We right now are looking at a comprehensive set of reforms specifically around substance use disorder, as many other states are, quite frankly. And methadone is on the table. One of the challenges has been that that's typically a daily administered medication observed, and therefore there's been a little bit of debate about what you need to pay for in order to ensure access, like covering transportation costs. The other thing, if you look, methadone is only available through narcotic treatment programs, NTPs, and right now the infrastructure for NTPs across Kentucky, there are large gaps in the reasonable driving distance to receive that care. So we know we are going to need to make it much easier to get through the prior authorization of any medication-assisted treatment. Methadone is one of the things that are on the table. Another example is just looking at, current restrictions on who can deliver residential treatment for addiction. So there's a whole host of programs. You're right that while we have one of the most progressive set of benefits, there are some things that are missing from those, and they're under active discussion.
When you were talking about the Medicaid population receiving care like in ERs or more expensive venues than a primary care physician, so part of the big issue, there's a couple issues, but one is there are very few providers that take new Medicaid patients. So that is a barrier to primary care. So those patients are coming to the ED instead. So that's one of the issues. The other issue is that people that have never had insurance before now have it, but they don't know how to navigate it. It's hard enough for people that have had it always to navigate the system, but now there's a navigation barrier for them, so they go the first place they can find, which is the ER a lot.
Yeah, so I'll take a quick response, then I'd really be interested in Ohio's experience. What do we know? If you look at the expansion population and the rate of primary care uptake, defined in a really broad, liberal way, for example, any visit with a person who would self-identify as a primary care provider, or a more stringent way, diagnostic codes for a health maintenance visit. Less than 1/3 of our current expansion population has any evidence of primary care. And then if you go further and look for things like screening for high cholesterol, a colonoscopy, a screening for breast cancer, the gaps far outweigh the limits on access to care. The other comment briefly I'll make is that, we're required to look at network adequacy. So we do our report, the managed care organizations do the report, and on paper, which I would acknowledge probably differs a lot from the situation on the ground, we have an adequate network. So I think there are things beyond the number of clinicians who can take Medicaid patients and
Taking new ones though. Providers cap how many Medicaid.
yeah. I would say that it's a debatable phenomenon about where the choke point is from my point of view. Director Sears?
Maybe I would just add some of the struggle that we've had. It's an interesting comment you made. So prior to, well, even when I was in the legislature, but prior to my taking a job with the governor as a director, I also owned a health insurance agency when I worked in that for about 35 years. And so I'm used to that idea of, great, I have a card and I have no idea what to do with this card, right? Card means you're entitled. It doesn't mean you know how to do anything with it. And so you do have to teach that. And one of the things that we find that has been interesting with the over 100 to 138% of poverty folks is even just that small increase may have meant they at one point in time had prior exposure to coverage, so they knew how to use it more. They also knew what was available more because they were more engaged in the workforce. They probably had more access to technology, so they could find things out more. So that's been an interesting concept to try to research and see how that interplays with cost. But specific to your point on the managed care plans, we charge our managed care plans with access to care. And so if they have to pay hospitals or providers additional in order to get access, and access isn't a name in a book or a name online, it's somebody who's actually taking new patients. So we actually hold them to a high marker on that. And I believe, with exception to probably a handful of counties, clearly we have spots, everybody does. But I believe we've got fairly decent access to care in that area. But it's not without a lot of pain or a lot of difficulty in some areas. I mean, I've got two counties that are side by side that I don't think they have a primary care doc in them. And so clearly that's a problem. But we are actually starting to go through our process again and look at what does access to care mean and how much does it cost for providers. It's an ongoing issue. But quite frankly, I think even if you had the best commercial insurance plan around, I think there are some areas that it's hard to find access to as a new patient. I don't think it's specific to Medicaid only.
Back there?
Hi, this is Trudy Matthews, and I'm with the University of Kentucky Regional Extension Center, and we have 2 contracts with CMS to help with preparing providers for moving into value-based payment programs and working on MACRA and quality payment program preparation. And so for both of you, this is a large national move. Providers are having to use data in new ways to demonstrate improvements in cost and quality and using their electronic health records in a meaningful way. But a lot of what we hear in going to hundreds of provider offices all over Kentucky is, hey, when is Medicaid going to get on board to help make, to align this? This is a lot of work to do just for Medicare patients. We need commercial insurers and Medicaid to make the same changes. Otherwise, this is just a lot of work and a lot of burden. We're ready to move that direction. If everybody was singing off the same sheet of music, we'd do it as well, but we need to know where Medicaid's going. So can you all talk to how Medicaid is going to be supporting the move to value?
You want me to start?
Can we take over the next hour?
I could. They might not like that. So through Ohio, we're doing a couple things. Number one, to the gentleman's point on our redesign. That was a big move in the state of Ohio to get BH redesigned. Finally, 1-1, please. We're going to finally recognize that a person doesn't get lopped off at the head and is segregated into 2 different areas. But not only does that integration of physical and mental health improve our ability to manage somebody's care, it also goes to your point of paying for value. And to that very specifically, we used essentially 11 different codes in the state of Ohio for all of our behavioral health addiction services. And now we're moving into a code set that will match commercial code set. We hope that will improve access as more providers are able to provide care both with Medicare, Medicaid, and commercial. But then that also allowed us to use our state innovation money, our SIM work that we're doing with CMS, and look at it both in our comprehensive primary care space and also in our episode space. So in our primary care space, we are working with 9 of our carriers, I think it's 9 of our carriers within the state of Ohio, that at full tilt, when we're fully up and engaged, will represent over 85% of all of the insured folks in the state of Ohio will be engaged in some kind of paying for value model with our primary care doctors, looking at how do you begin to pay for and embed some just beginner, 101 type ideas of social determinants of health into a primary care office so that you can then build on that and engage up. But then what are the referral patterns of those primary care physicians? Who are they referring out to and what's happening over there in the episode world of specialists? So we've done now 3 waves of our episode work. So we have essentially different, about 42, 43 different episodes of care that we're engaging on. And we very specifically picked physical health, and we very specifically picked some behavioral health episodes so that we can look at what is best practice, high quality, and where does cost intersect in that conversation. And then when I came on board, I come from a dental family background, I said, well, what about dentists? Particularly when we're looking at prescribing habits and the opiate issue. We know that dentists are engaged in that space also. So we actually added a dental episode to it just so that we could capture that predominantly the prescribing habit conversation in that. And so now we're looking at these episodes of care, and we're able to go out to a primary care doc and say, you know what, 60% or some odd percent of your referral habit is to providers A and B, but provider A is very, very high quality, low readmission issues, low follow-up issues, and very, very low expensive. Well, provider B is mediocre on the quality of care and 3 times the price. And so now we're being able to show that, but we're doing more than showing, we're funding to it. So we're using some of those dollars to actually pay upside downside risk. So our primary care, I think we've sent out 3 payments, and that's like a month to month per member per month based on folks that belong to their practice. The other one is based on quality and price intersection, and it is upside downside risk.
Yeah, so a quick answer and then a couple of longer answers. One quick answer is for substance use disorder, we're likely going to have a bundled payment that'll streamline kind of jump-starting new infrastructure and really also hopefully give the providers kind of less bureaucratic documentation and a more straightforward way to be paid for good care. A couple of, Gil's view of the world. One, take, for example, our expansion population again. We really don't know what it costs to take care of them because we have yet to get them into care and really understand what their health needs are. So you need data to really develop kind of, what's the shared opportunity or shared risk. The other is, unfortunately in Kentucky, my perception is we don't have the comprehensive integrated systems where ambulatory settings are connected with inpatient settings so that you can transfer care delivery from less efficient, more costly to, the opposite of that. So what have we been doing? What have we received? We have had a complete fee-for-service delivery system in our state, by and large, and we've seen the perverse, unintended, unwanted consequences of that. Volume-driven approaches to medicine. The MCOs try to get you for the lowest contract that they can. There's lip service to, well, if you're high quality, maybe we could give you a little higher payment. But behind that, and the information technology doesn't support population health like it should. Right now, it is an anchor dragging clinicians down, not a tool helping them really understand, I own this group of patients and I need to treat them differentially so that we steward the limited dollars the best we can. Final comment, expansion, it was initially covered 100%, but it ratchets all the way down to 95% in the near future. Our state cost share for that 5% payment is not sustainable right now. We're going to have to pull money away from other things that need investment, pension, education, roads, whatever the case may be. So we have to get towards a higher quality, more sustainable cost of insuring Kentuckians. So yes and amen. Medicare is going to drag us kicking and screaming there. Hopefully Medicaid will find a way to kind of get ahead of the curve and not be reactive about it. But.
All right. Yep. Thank you very much. Let's give another applause for Dr. Sears and Dr. Liu. All right. And I'm going to turn this back over to Rochelle.
Folks, we are in our last session. I want to thank all of you for coming today. I want to welcome to the stage the panelists for session number 3. And our moderator this afternoon for this session is Dr. Camille Jones. She's the Assistant Health Commissioner at the City Health Department in Cincinnati. Please help me welcome Dr. Jones.
Greetings, everybody. So, this is the last session of the data conference. The title is City Leadership, Health, and Data. We have 3 speakers who'll be talking each for about 12 minutes, and then a final question and answer period. I'll be introducing the speakers all at the start, as we've been doing all along, and then ask the first person to come up. Our first speaker will be Mayor Brandy Harless from the city of Paducah, and she will be speaking on creating the healthiest city in Kentucky. Our next speaker will be Mayor Rick Skinner for the city of Williamstown, and he'll be speaking on collaboration plus data is equal to results. And then our final speaker will be Ms. Lee Tammy, the Chief Performance Officer of the City of Cincinnati, Office of Performance and Data Analytics, and she'll be speaking on public health and open data, how the City of Cincinnati is using data visualization to combat the opioid epidemic. We'll start with Mayor Harless.
Well, good afternoon, everyone. Are you wide awake? I was told I was supposed to give a high energy presentation, so I'm going to do my best. Everyone back home knows that I have lots of energy, so I'll try to temper it for you a little bit. But first of all, I'm thankful to be here. Thanks for asking me to drive almost 5 hours all the way over to join you today. And shame on me, I chose to do it this morning, so I've been up since about 3:45 a.m. So if anyone's tired in the room, it's probably me. Well, I wanted to start by giving a little bit of background about me, because before I was mayor, I was, and I still am actually, it's a part-time job in Paducah, full-time effort, part-time pay is like what I like to say. But I am in healthcare, so I actually have my own software company. We help primary care providers embed primary prevention and behavior change into their clinic. I'm actually called a healthcare transformer by my entrepreneur coaches up in New York City, so I'm really proud to be here among all of these very bright-minded healthcare experts in the room. And you know, this is one of my first presentations to mix my job as mayor with my world in healthcare, so I'm excited to be here to do that. I did just become mayor in January of this year, so it's my first term. I have 3 more years to go. No one's counting. No, it's been great, actually. I've learned a lot, and I can't wait to share with you some of my big visions for our city over on the western part of the state. But before I jump in, I want to share a little story with you because it kind of gives a little insight into where my mind has been when I've been thinking about the concept of using data in decision making and in public health specifically. So when I was in grad school at Boston University, I had an opportunity to work at Harvard University with the professor there, Teresa Betancourt. She actually has her master's degree from University of Louisville. She's from Alaska originally. And we did the first ever longitudinal study on the reintegration and mental health of former child soldiers in Sierra Leone, West Africa. So I fly myself over there. It's 2007. It was my first year of grad school. I get on the ground. I'm doing the 3rd wave of research. We did 1,250 something interviews across the country of Sierra Leone. And over and over and over again, the people we were interviewing, it was the 3rd time we were interviewing them, kept saying to me, "Why are you asking me these questions again? You said that last time you were here and you brought me the bag of rice and all the stuff, you said that you were going to be offering me something for all this information. That was the point of doing research, right? That you would help us." Well, this was the 3rd time that the study had been done in 11 years, and no intervention had been created. So I call my professor, who is like, all right, this young whippersnapper of a grad school student thinks she knows something. And I just am like, why in the world are we not doing something for the people that we're asking these questions to? So it was one of my first lessons in this delicate dance between when's enough research to actually take action. And that has really driven me in my career since then. This delicate dance of how many times are we going to collect information and collect data until we actually get to action. So I've fallen in love with the concept of human-centered design, and I'm not going to talk about that today, but that has really gotten my head around how do we do this kind of rapid prototyping in the work that we do so that we can collect information, but that we can act on it more quickly so it doesn't take 11 years sometimes to collect that data. So that's a little bit of the background of kind of where my head is whenever I'm sharing with you what I'm about to share with you. So I do have this lofty goal. I know all of you in Kentucky think that you're going to try to beat me at it, but I am going to try to create the healthiest city in Kentucky over the next 3 years. That is my goal. I'm going to share a little bit about where we've been. So this is an evolution of my experience in Paducah. I accidentally moved home in 2009. Literally accidentally. Promise you, I'll tell you the story another day if you ask me. But this is kind of my evolution in experiencing community health and healthcare in Paducah and the work that we've done. And then I'm going to get to being mayor and be able to share with you where I think we're headed. So, who's been to Paducah? All right, that's a good one. All right, okay, who hasn't been to Paducah? That's okay, don't be ashamed. All right. It's not really 5 hours, it's about 4.5. So it's not that bad in the daytime with no rain. Pick a good weekend and come visit me. But oftentimes in Paducah, I feel like we are standing with our arms like this, waving really loud and high, like, hey, we're over here, you know. And recently, an economist from the University of Louisville was speaking to my Leadership Kentucky class, and I came up afterwards and asked him, why didn't you talk that much about Western Kentucky and Paducah specifically? And he said, well, I've actually always seen you as a very self-sustaining city. You rarely come and ask for things. You are always working so hard on your own. You guys have really created your own identity. And I think that's very true for health too, for us moving forward. So we started along about 2012 when I started getting involved in the healthcare conversation. And we started something called the Impact Poverty Study. And a wealthy businessman in our community started recognizing that the poverty rates were going up tremendously in our city, specifically in Paducah. And they went out on an effort for 2 years to study what was happening with people living in poverty, how can we prevent it, and all of that good stuff. We learned a lot, and those things can be found on our local United Way website. But the one thing I wanted to mention was the way that we utilize data in that scenario. So not only did we take all the secondary data and all that kind of stuff that we could find from our partner organizations, but finally someone within probably the first year kind of had this aha moment. And someone talked about participatory-based research earlier. Someone kind of had the aha moment that no one sitting in the room was living in poverty. And so we needed to get our heads together and figure out how we were going to actually include people who were living in poverty in our poverty study. And so we actually went out and recruited the Bridges Out of Poverty program. We utilized the Getting Ahead curriculum and started really asking and diving into what was going on with our citizens living in poverty. One of the outcomes from that was the recommendation that we should have a community health center. So at the time, I was actually working with St. Nicholas Family Free Clinic at the time. And it was the largest free clinic in our region. I was the director at the time. We had 11 different counties we were serving, about 4,000 patients we were seeing, only a $500,000 budget a year. It was absolutely insane what we were able to do. And as Medicaid expansion was coming down the pipeline, we started really asking ourselves, are we going to be able to sustain once our patients get on Medicaid? We just assumed most of them would. So we started doing all the data analytics and said, you know what, 95% of our patients are going to be eligible for Medicaid. We don't have the expertise in our organization to be able to bill Medicaid, so we need to figure out how we're going to solve this problem. At the same time, our donors were telling us, well, we're not going to give you any money. Has anyone had this experience in your community with free clinics? We're not going to give you any money because the government's going to take care of it, so why would we keep donating? Well, that put us in a panic, and so for the next year, we said, okay, well, the Impact Poverty Task Force said we need a community health center, and we're having this problem simultaneously. We need a federally qualified health center to come in. And we had a really hard time in Paducah, and really west, the whole Purchase District, getting any of the federally qualified health centers to come over our way. For whatever reasons, it doesn't really matter. So we actually found out that Our Care out of Arkansas had started a clinic in Carlisle County, which is like the furthest westernmost county in Kentucky. So we recruited them to come in and partner with us. And so what we did, we actually turned St. Nicholas into a foundation that was able to be nimble to the new needs of people who were having a hard time paying their premiums or deductibles, whatever that may be. And we recruited Kentucky Care in as a federally qualified health center. So now they have 5 locations in our region. They are solving our access problem. They actually can't get full. They have tried, and we're still working with them to make sure people know to seek their care because they are providing that to our patients in Western Kentucky. So that was a really great success story from the Impact Poverty Task Force. We actually were supposed to do that in 10 years, and we ended up doing it in 2. And so it was a great success story for us. And you know, for me, in my perspective, this is the one thing I wanted to share for sure. When I came in as a trained public health professional who wanted to use all of these like processes and data-driven decision-making processes to help my community make decisions, I quickly realized that the learning curve was so steep in my community and people did not know what I was talking about. Now, take away the health department experts and those kinds of people who definitely understood, but my community organization volunteer board had no idea what I was talking about. And so it was a struggle for me to figure out how do I help push towards this big vision with the data that I understand is important for us to respond to, but also building this kind of community collaboration along the way. So fast forward to this year, and the Commonwealth Fund out of Massachusetts calls us and says, well, you guys are going to be a case study for us because you have improved on more of the metrics in our local index than most of the MSAs across the country. We were shocked. This was not an outcome we were headed towards. It was nothing we meant to do, but we stood out on their radar, and now we approved 17 of their 32 indices. and we are now one of their case studies that they're using. And so that website was actually the article that was recently published about our work, and they gave a lot of credit to the work that we did by expanding access. Medicaid expansion also was probably mainly our driver, but definitely how we responded to that was something that we got a lot of credit for. And I'm proud of that, because I think even though we weren't going about this in the kind of way that I would want to, with the super methodical implementation, we were doing it as a community and in collaboration, and I think that helped us tenfold. So today, we now have the Purchase Area Health Connections Coalition. And this is where I'm fairly certain we're going to see our region start to embrace that data-driven process that I'm hoping for. Because we now have a place, someone mentioned data sharing, and that there's a desire and need for trust to do that. We have been building the trust for 5 years now. And so when we come to the table to talk about how we're going to share data or go after a project or a program, the walls have come down. We have two of the largest health systems in our community. We have Baptist and Mercy. They've always been at odds with each other, but we've brought a lot of their employees onto our coalition together, so we're starting to watch those barriers break down, and we're able to have the kind of